How do you?
You can start your session, Dr. Prashant.
Yeah. Thank you. Good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. Doctors, as you know, this webinar is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993 with 30 years of excellence and 36 state-of-art manufacturing facilities. Heathrow Healthcare has 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and Heathrow Healthcare is the largest closely held pharmaceutical company in India. Amongst the largest manufacturers of ARV, APIs, and FDFs in the world, Heathrow Healthcare has Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and Heathrow Healthcare has a distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneer in antivirals, offered Oseltamivir, favipiravir, and remdesivir to the patients, because of which, in August 2020, Heathrow Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, role of Oseltamivir in flu management, we have got Dr. Pramod Zog sir as our moderator, and Dr. Anil MU and Dr. Somashekar as our speaker. Welcome Dr. Zog, welcome Dr. Anil, and welcome Dr. Somashekar. Dr. Pramod Zog sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee member GAVI CSO 2016 to 2019, Chairman Mini Recipe Module IIP, author of book Cophology. Professor Dr. Somashekar is Professor Ramaya Medical College, Pediatric Pulmonologist and Adolescent Care Specialist, President IIP State Respiratory Chapter 2015-16, Treasurer IIP Allergy Chapter 2015, IIP State Allergy Chapter, Joint Secretary IIP Bangalore 2016, Secretary AHA 2016-17, EB Central IIP Respiratory Chapter, EB Central IIP 2015-17, Secretary IIP State Allergy Chapter 2021, Chief Editor Pulmoscan, Executive Editor Journal of Pediatric Pulmonology, EB National Respiratory Chapter 2023, Secretary Environment Chapter of Child Health Group IIP 2023-24, President IIP Bengaluru 2024. Dr. Anil MU sir is MBBS MD Pediatrics with Fellowship in Pediatric Critical Care and Diploma in Allergy and Asthma. Sir is Lead Consultant in Pediatrics and Pediatric Critical Care, Sparsh Hospital, Bengaluru. With this brief introduction, I hand over the session to Dr. Pramod Zog for further deliberations. Over to you, sir, and I stop sharing.
Are you able to see the slides, sir?
Yes, sir.
Yes, sir.
Thank you. Thank you. So today we are going to discuss about influenza and the use of oseltamivir in flu management. And remember that the monsoon is in full swing in many parts of our country, and viral infections affecting the respiratory system, influenza, are in full swing. And our practitioners are in fact too busy managing these cases. And we will try to clear certain doubts related to these upper respiratory infections, which can also get complicated. Of course, remember that it's not only the airborne diseases, but also the mosquito-borne diseases like dengue, which are also prevalent in the monsoon and the post-monsoon season. So we have to look at this picture as an overall picture. And I am fortunate to have Dr. Anil and Dr. Somashekar along with me to answer some of the queries in the minds of our listeners. And as you can see, influenza virus has a particular nomenclature, and I have tried to put my name in the same fashion, like the place of origin, the month and the year of origin, and the name of the strain, and so on and so forth. Of course, I was the IAP presidential strain of 2016, and every year these strains keep changing, just as in case of influenza. As I said, these viral illnesses have been benign for quite a few years, but of late, some of these viruses have started, behaving in a different way. And on the fourth or the fifth or the sixth day, we have started witnessing what is called as cytokine storm, which was so much seen during the COVID times, and we had tough time managing those patients. Of course, in case of COVID, the transmission is usually from adults to children, and that's why vaccination and all other efforts were more centered towards the adults in the beginning. But in case of influenza, RSV, basically the transmission is from children to adults. And that's why it is important that we discuss this topic of influenza in the forum of pediatricians. And during COVID, children as well as adults, they did not develop immunity against certain viral infections, RSV and influenza being some of them. And I remember during COVID times, the incidence of RSV also had dropped down to almost zero. And that was related to the use of SMS, that was those sanitization and the wearing of the mask and the social distancing. And in almost all the countries, including US, RSV had dropped down to a great extent. Of course, viruses like RSV, when they get together with other viruses, for example, human metapneumovirus, they play a havoc. And, the intensive care specialists have a tough time managing two viral infections together. And that's why these days we have to be very careful when a child comes with, viral infection. And I would put those viral infections into inverted commas, because today the child appears fine, but after 3 or 4 or 5 days, some danger signs might develop, and we'll have to be quite alert. And I always ask my parents to report back after 3 or 4 days, even if the fever goes down, I tell them to report back. I usually do not charge them when they come back again, because at that time I always believe that I am learning from the patient. What happens on day 3, what happens on day 4. So the patients are happy many times, but we have seen in case of some of these viral infections, there could be a second phase, and that's why some of these illnesses, they are biphasic, illnesses like influenza and others. And you can always see that along with recurrent respiratory infections, some of these illnesses like otitis media, adenoidal hypertrophy, and then adenoviruses, all these are showing a different kind of a trend over the last few years. And adenovirus and RSV and this hand foot mouth disease, all these, they showed a bit of an upsurge after the decline of COVID, because there was no immunity against some of these viruses. And I remember in some of these parts of our country, even measles was showing rise in the cases, because those were the cases where immunization was on a lower side. So recently, when I got a child, a 3-year-old boy with fever, cold, and cough, with tachypnea and hypoxia, and an X-ray picture showing like ARDS, admitted to the PICU, ventilated, who received Oseltamivir along with supportive therapy, and turned out to be H3N2 positive, was ventilated for 3 days and then improved. Many questions came up in the mind as to whether we could have prevented, some of these progressions of some of these patients. So when a child comes in the OPD with respiratory infection, we are in two minds. In the beginning, it's very difficult to differentiate whether it's a bacterial infection or a viral infection. If it's viral, which is the virus, whether it's a rhinovirus or adenovirus, RSV, human metapneumovirus, enterovirus, coronavirus, influenza virus. If it is influenza, whether it is H1N1 or H3N2, and whether I should start oseltamivir upfront, particularly in the monsoon season, to play safe, and whether there are any guidelines which would direct our colleagues for proper and rational management. Influenza-like illnesses are rampant, and flu is the topmost. I always say it's the father of all the influenza-like illnesses, because it presents with severe body pain, weakness, and parents many times have to lift even the older children, and get them to the OPD. There are many healthcare-related challenges in monsoon, and as regards influenza, the mortality and the morbidity have been on rise over the last few years. Influenza vaccine does give protection, but not to a great extent. It gives a protection to the extent of about 60 to 70%. And the coverage of influenza vaccine is also not to the great extent. And that's why influenza still prevails. let us know a bit more about this naughty influenza virus. I call it naughty because it's an RNA virus. RNA viruses are notorious to change their structure, and that's why viruses like COVID, RSV, influenza, all those RNA viruses, they will change their structure. Influenza A is the one which causes frequent epidemics due to minor antigenic variations. On the outer side of these viruses, there are some glycoproteins like H and N, hemagglutinin and neuraminidase. And these amino acid sequences of these glycoproteins, they keep changing. There are some 16 H viruses, type H glycoproteins, and some 8 neuraminidases of different types. However, the H1, 2, and 3, they usually are the ones which infect the human beings, and they get combined with N neuraminidases. So the usual combinations are H1N1, H2N2, H3N2, like that. The numbers like 9 and 5 and others like H5N9, they usually create the problems in the birds and the animals. And influenza A infects animals, birds, as well as the human beings. And that's why mixing of all these viruses takes place in some animals like pigs. And that's why we had swine flu, which was, the one responsible for a major pandemic in 2009. And this was also the reason for the pandemic in 1919. What happens is that the flu viruses from the birds and the human beings, they get into the pig, and the pig acts as a mixing vessel, and a new type of virus comes from these. And that is the major pandemic, and that is because of the major shift. So what happens annually is a drift. What happens once in a while in 10 to 40 years is a shift. And then influenza B viruses are the ones which infect only human beings and produce local epidemics. As influenza B doesn't infect the animals or the birds, it doesn't lead to pandemics. And as I was telling you about hemagglutinin and neuraminidase, hemagglutinin is the molecular key. That's the glycoprotein which attaches to the respiratory epithelial cell. The RNA of the virus enters into the respiratory epithelial cell. These RNA, they multiply, and many virions are produced inside the respiratory epithelial cell. And those virions, they are ready to get out of the respiratory epithelial cell. At this level, the neuraminidase enzyme of the virus acts as a molecular scissors. It literally cuts different virions so that they could be released outside from the respiratory epithelial cell. Oseltamivir blocks this release of the virions, and that's why it stops the spread of the virus to other respiratory epithelial cells and further progression. As I told you, there have been 4 major global pandemics. The initial one in 1918, 1919, which affected almost 1/3 of the global population, was erroneously called as Spanish flu because it also involved quite a few parts of United States. Then came 1957, the Asian influenza, 1967, the Hong Kong, and 2009, it was again the swine flu pandemic, which affected world over. So, Dr. Anil, what are the recent updates in the epidemiology and the circulating strains of influenza viruses, particularly affecting the pediatric population in India and maybe in Bangalore, where you practice?
Yes, sir. Thank you, sir. It was a very succinct explanation about the epidemiology and the various strains which are going around. Like sir mentioned, we are having currently a local epidemic which is going on. This is mainly of the influenza A variety is going on right now. And even when we look at the subtypes, we have the two major subtypes which are going around. One is the 2009 pandemic strain, which has now become locally endemic. That is the H1N1 strain is going on. And the second one, I think H3N2 is being detected more in numbers currently. But when we look at globally, H1N1 is much more predominant than the H3N2 subtype. And like sir told, influenza B can cause local outbreaks, especially the Victoria lineage. We had even heard about the Yamagata lineage, which is still included in our quadrivalent flu vaccine. But since that Yamagata has not been isolated starting September 2020, most probably coming year we'll have only a trivalent vaccine, which will include H1N1, H3N2, and the Victoria lineage may be there. And these are the three subtypes which are going around right now.
So we now are aware of what are the viruses in circulation. And it is known that influenza is the one which comes up after a major pandemic. So after COVID-19, these viruses, particularly type B, which affects the eastern part of our country, it started making its appearance after the downfall of the COVID. So, in the nature, when one viral infection prevails, other viruses do not, create any problem. But when one viral infection starts going down, like for example, COVID, other viruses, particularly influenza, starts coming up. So this virus, basically spreads, by droplets, and these are the droplets which spread when people cough or sneeze or talk, and they land in the mouths or the noses of people who are nearby, and the transmissibility of this virus is very high. And in a short incubation period, all the members in the family or children in the classroom can get infected. Dr. Somashekar, after infection occurs with a very short incubation period, what are the different clinical scenarios with which influenza can present in the pediatric population?
Dr. Pramod, you have well explained about the overall statistics and the presentations and the present relevance of this topic. The majority is what we are seeing. It's all OPD practice. The season is of viral winter, and we are seeing a lot of cough, cold, coryza. These are maybe it's RSV virus, adenovirus, or influenza-like illness. That's all there. But why you are talking about influenza per se is they are the one who, like, few percentage of them, they go for complication. What are those? If they got persistent symptom, how to identify? If they have same cough, cold, upper respiratory like illness and the symptoms reflecting the same, by third day or fourth day, if they become sick, if they become overtired, disproportionate tiredness, if they got vomiting, diarrhea, or other complications like febrile status or progressive pneumonia, respiratory issues, they are all the one. These are the pictures. But apart from OPD, what is in the inpatient we are seeing? Maybe a case of bronchiolitis we are seeing, which is refractory to treatment or requires high dependency, observation, or case of febrile status, or maybe becoming to encephalopathy. 2-3 scenarios of nephrotic syndrome going for complications like shock we are seeing. Dr. Anil has mentioned few of the real complication where they had to do the critical assessment and the train interfere. All those things are there. These are all the common state. Apart from that, what is the classical about this picture is that this influenza is they have other extra respiratory symptoms like vomiting, diarrhea, headache. All those things are the common. These are all the common clinical pictures going on in the surrounding with the present situation of influenza or influenza-like illnesses.
So one must remember that viral illnesses usually affect different systems in the same child, and that's why one should not be surprised if a child comes with fever, cold, and cough along with gastrointestinal symptoms. And of course, in the latter part of today's discussion, we will request Dr. Anil to elaborate more on the complications related to influenza.
Yes.
So as of now, we will just proceed and see some of these symptoms of illnesses which affect the respiratory system, and you can see that symptoms like fever, myalgia, and then cough, and the lack of energy and the sore throat, almost all are very common to viral respiratory infections like influenza-like illnesses, H1N1, severe acute respiratory infections, and COVID-19. However, there are certain symptoms. For example, in case of COVID-19, we know that the loss of smell and the loss of taste were predominantly noted. In influenza, we just discussed that a lot of weakness and headache and muscle pain, they predominate, while in case of other viruses the symptomatology may vary, but in general the symptoms are quite common, and it's very difficult to differentiate these viruses. But at the same time, it is essential to have a high index of suspicion for influenza, because it is one of the viral infections affecting respiratory system which is eminently treatable by Oseltamivir, and that's why we have to be clear about some of these presentations. So, Dr. Anil, we would like you to elaborate the emergency warning signs of the illness influenza.
Yes, sir. I think these are the red flag signs that we look out for. And at the same time, when we are treating the milder cases of flu in our OPD, we need to educate the parents about these red flag signs, to watch out for these signs and get back to us if at all there is anything. So any of these red flag signs are there, it is for us to identify and immediately admit the patient. or to provide the necessary supportive care. The most important thing is how is the child doing in the interfebrile period is what we need to look at. So if at all the child is becoming active, is the child active or is the child becoming dull, lethargic is what we need to look at. And if you look at system wise, respiratory system wise, if at all the child is developing any fast breathing, respiratory retractions, respiratory distress, these kind of things we need to look at. And CNS wise, we need to see how active the child is. Is the child drowsy in between? Is the child very lethargic? Most important sign we get is how well the child is able to feed, how the oral intake is. That will also tell us how well the child is doing. So any of these red flags are there, the child should be immediately seen and attended to immediately.
Thank you. So flu can create complications, and I have just enlisted these complications with the alphabet A to remember in a simpler way. So flu can complicate as acute respiratory infection in the form of pneumonia or get complicated into ARDS. It can also lead to acute otitis media, and it can also lead to school absenteeism. And as the initial picture could be confusing for our clinicians, it can lead to antibiotic abuse. Basically, viruses like RSV or influenza, they damage the epithelium, and these are epithelial diseases. And that's why after this damage, it's very easy for bacteria like Streptococcus pneumoniae or Staph aureus to get colonized, get localized into the respiratory epithelium. And that is the reason why acute otitis media is the complication following flu. And the treatment of influenza has been categorized into category A, B, and C, and we will shortly come to that. Just before that, we will have a look at this antiviral drug oseltamivir, which I already told you is a neuraminidase inhibitor, and it is critical in releasing the virions from the infected host cells being prevented. And it is a selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B. And it's a prodrug which is converted to the active form oseltamivir carboxylate in the liver. And it inhibits influenza virus replication and the pathogenicity and further spread of infection. This is a diagrammatic representation as to how oseltamivir blocks the release of new virions. And this molecule was the first oral neuraminidase inhibitor, and it has been approved in more than 100 countries and also approved by CDC and American Academy of Pediatrics. Dr. Somashekar, what are the different categories for treatment like A, B, and C? And after that, we will see the recommendations for the use of oseltamivir.
See, this is very important to know the category because that's how we can triage the illness so that we can plan the treatment. So category A is uncomplicated. We can call it as mild. And usually the patient will have mild fever, cough or throat, like any other respiratory infection, either bacterial or viral, majority viral. They may have a headache, and in these influenza-like illnesses, they may have diarrhea, vomiting. They are all self-limiting. Category B is the one where we should be sensitive and we should be alert. They are high risk and they have severe symptom. This includes persistent high fever, severe sore throat, and apart from the symptoms of category A is also included, like headache, diarrhea, vomiting, body ache, all those things are there. But what is the specialty of category B is that the children's high risk conditions are in such a way that the children less than 5 years or especially less than 2 years are considered as high risk, and including pregnant women and the geriatric age group more than 65, they are considered as, they comes to category B. Apart from that illness, if they got chronic lung condition like a chronic any COPD or uncontrolled asthma, cardiac coronary heart diseases, or chronic renal diseases, or any transplant situation, and diabetes, fully controlled diabetes, progressive neurological disorders, and cancerous condition or retroviral diseases, poor immune state, they are all considered comes in the category B. This is the where you can do the triage properly. We can consider starting the treatment as early as possible based on the symptom scoring. And important thing is not to forget about the patients on long-term corticosteroid therapy. You should be alert in this case condition. What is category C? Category C includes uncomplicated mild symptom as well as complicated like high risk and severe symptom. The category C is the where mandatory you should start treatment. That is how, what is that? They'll have acute complication. Maybe they'll have acute breathlessness, chest pain, hypotension, low blood pressure, sputum. They all can or decreased activity or persistent cough, progressive cough, breathlessness, chest pain. All this comes to category C. So knowing the category A, B, C, we can triage the one second symptom. We know when to start oseltamivir or the self-limiting. We can reassure them to tell the red flags and or to start the treatment.
Thank you. This is the summary of the treatment guidelines which Dr. Somashekar already elaborated, where category A necessitates only bed rest, plenty of fluids, and paracetamol for fever. Remember, aspirin is to be avoided for the control of fever and the muscle pain, because we are worried about the complications like Reye syndrome, which is a form of hepatocellular failure with encephalopathy. And of course, over last few years, we have not seen so many cases of these, but during our residency days, we were really very much worried. Category B is the one where this therapy is combined with antivirals started early, before 48 hours. And during this particular category, one may test the nasopharyngeal swab if in doubt. And in category C, the testing is to be done immediately. These are the children who are usually hospitalized. They have to receive antivirals like oseltamivir along with supportive therapy. And this is the dosage and the recommendation of oseltamivir. The therapeutic dose is given for 5 days and the prophylactic dose is given for 10 days. In adults, the dose for therapy is 75 milligrams twice daily for 5 days, while the dose for chemoprophylaxis is 75 milligrams once day for 10 days. And in children, the dosages are dependent on the weight bands, and they range from 60 to 90 to 120 to 150 milligrams per day. But for therapy, they are divided into 2 doses, while for prophylaxis, the doses are 30, 45, 60, and 75. These are given once in a day for 10 days. In infants who are less than a year, the dose is 3 milligrams per kg twice daily, and chemoprophylaxis doesn't apply to infants. Dr. Anil, I would just like you to tell our listeners as to how early initiation of oseltamivir influences the clinical outcome.
Yes, sir. Lots of studies, well-controlled studies, have shown us that initiating this oseltamivir early in the course of the disease, like just before 48 hours, will reduce the duration of the illness by almost 1 to 2 days. Anyone who has gone through this kind of a very tiring, high-grade fever, body pain, headache, and with the long list of complications which may follow, will vouch for it that even that reduction of 1 to 2 days in the duration, it's a really a good gain. So if it is instituted before 48 hours, it will give us the best results. But say in the institutions where we practice, sometimes we may get late referrals by even day 4, day 5 also, who will have to be hospitalized. Even in such children, we should not deny them from the benefit. We should go ahead and start them even if it is day 4, day 5. Like what Pramod sir told, these are the molecular scissors. So it will prevent the virions from getting spread all across the other systems. So by using this even late in the illness, we can prevent the complications which may come up. So definitely useful. Best is within 48 hours. Even late, we can continue to use it.
So even if the patient is brought after 4, 5, 6 days, and in case if the child has SPD distress and is admitted, please do not hesitate to start with this molecule, because at any stage it can prevent the further spread. And
as Anil said,
yeah,
mean duration of stay comes down as well as viral shedding, and the viral load also comes down. Whatever the dose of benefit, please start it with a high index of suspicion.
sure, yeah. And then this has been definitely proved in clinical trials, where in patients with influenza, oseltamivir treatment reduces antibiotic use, influenza-related low respiratory tract complications, and hospitalization, not only in children, but also in adults. And Dr. Anil, what is your opinion about oseltamivir, whether it should be started empirically or it should be started after investigations?
No, sir. I think majority of the cases we go ahead and start it empirically. Especially we have a background of epidemiologically lots of cases of flu being detected, we don't wait for the confirmation of diagnosis in such situation. So clinically, if it's acute febrile illness and it's fitting into the syndrome of ILI or influenza-like illness, there is epidemiological correlation, and its child is falling in category B or C. Of course, A, we have time to wait and watch, or it is not indicated at all in category A. Category B and C, we need to go ahead and start it empirically, because just now we discussed the best results are if it is started as early as possible, less than 48 hours, it will give us the benefit. So category B and C, we need to start empirically also, even without waiting for the flu swab results.
Right. And of course, this has been also substantiated by guideline recommendation from WHO, where empiric treatment is strongly recommended, and the treatment should be started as soon as possible. And the laboratory confirmation of influenza is not necessary for initiation of the therapy. And one should remember that even if the laboratory test for H1N1 doesn't come positive, one should always start Oseltamivir if there is a strong clinical suspicion. We will discuss about the role of these RT-PCR tests in a short while. One should remember that Oseltamivir has to be started there is a strong suspicion and empirical use is acceptable. Let us now discuss certain cases. And Dr. Somashekar, this is a child who has come to us with fever for 3 days and cold and cough. He has been on metered dose inhaler since 4 months and he is well controlled. And for the cold and cough and fever, he has received symptomatic treatment. But he remained afebrile for a day and again developed fever and came back again after 3 days. And in between, of course, the parents say that the child has been fine. This is a very common scenario, and where we have recurrent viral infections which have become more frequent. They occur at a shorter interval. So there are many questions whether we should treat by only paracetamol, whether we need to give antibiotics, whether parents would demand, and so on and so forth. So when you face such a child, how do you counsel the parents coming to your OPD?
Here is 3 days of fever with mild upper respiratory symptoms, and in between the symptoms is active, is not deteriorated or any progressive symptoms are there. And this is the season of viral illness. Just reassure them and tell them to come back after 3 days. Then you can check, because parents will be worried you are not started antibiotic. What is the course? They'll be worried about hearing to other stories also. Please tell them that this is a common symptom of upper respiratory. Treat symptomatically. A supportive care, you start it. Ask them to come after 3 days and tell them about the progressive symptom or when you want to start the antibiotic. If there is a persistent fever or develop any localized signs, or you may investigate also. Or further, any symptoms of influenza-like illness, you think of starting oseltamivir. Please have one-to-one discussion and counseling. Giving some time to them makes all the difference, rather than the antibiotic or starting oseltamivir.
Yeah. And Dr. Anil, do you have any additional points for our listeners?
Yes, sir. Just for reassurance, we can always plot the growth of the child on a growth chart. Show the parents that since the child is growing fine, and this is how the child is learning the immunity with each new viral infection that is happening, because the child
Yes.
is being challenged with multiple infections in the year when they're going to the pre-nursery or the school. So they're being challenged with multiple viruses, and this is how the body is learning the immunity. So we'll show them there is nothing wrong with the child. Child is growing along the growth chart, so not to worry.
Right. And I remember you
And
once
if they
told
are
me.
known patients of you, ask them to get the file and show them that, see, number of episode in a year,
Right,
five
sir.
to six is normal, and you are not started antibiotic, still he has recovered. So we can
Yeah,
just
yeah.
show them. That will be a very good evidence.
Yeah, sure, sure. And at the same time, we can tell them that so many other children are also unwell, so that you are not the only
Yes,
one. They are
Yes,
also
sir.
unwell.
Yes.
And I remember
absolutely.
Dr. Anil telling me, that take these viral infections as another member of the family, huh? So that,
Yes,
your child has to grow
he
with
was
this member,
telling.
provided the growth is normal, and, it also adds to the immunity of the child. Of course, there are different ways that our colleagues can tell the parents, but the essential thing is that, one should not rush to antibiotics when they are almost more than 100% sure that this is viral, isn't it? And of course, at the same time, one must remember some clinical clues for viral and bacterial infections. There are very common illnesses like rhinovirus, which produces only mild or maybe no fever. The child is not exhausted, has only cold and sneezing. The child otherwise is playful. So it's a simple upper airway involvement. In case of flu, as we said, the child might have high fever, prominent headache, myalgia, and extreme exhaustion. And then adenoviruses, of course, I always say they have started behaving like bad adenoviruses. They are bad because, they are creating a lot of problem. And in fact, they produce pharyngoconjunctival fever, diarrhea, mesenteric lymphadenitis, hemorrhagic cystitis, and the WBC count comes high, the CRP comes high, and many times, one is deceived and one starts with therapy with ceftriaxone for pneumonia and fever doesn't come down. And I remember one case where on day 15 or 16, people started thinking of adenoviral pneumonia because the X-ray picture also in that child was like lobar consolidation. Anyway, bronchiolitis, as we all know, is related to RSV and common under the age of 1 year. And bacteria like group A beta hemolytic streptococcus produces fever with follicular tonsillitis and tender cervical nodes. Pneumococcus will produce pneumonia and the child will come for fever, grunting, and rapid breathing. And staph will produce rapid progression and the child will be quite toxic. While organisms like mycoplasma affect children beyond 5 years and predominantly come with cough. So this is a child, Dr. Anil. You can have a look at the X-ray also. He was a 4-year-old child with cough, cold, and high-grade fever for the last 5 days. Did not settle with oral medication, and on admission he had tachypnea and needed oxygen support. The hemoglobin was 11.6. The total count was 1620. The platelets were 132,000. The liver function tests were deranged to some extent, and the nasopharyngeal aspirate was positive for H3N2. So we diagnosed this as a case of influenza with low WBC count and low platelets with derangement of the liver functions. So I would just like you to analyze and discuss this case for the benefit of our listeners.
Yes, sir. When the child comes to us, we still won't have the X-ray findings nor the lab reports with us. So conveniently, I think we can classify in this epidemic because this child is coming with a predominantly fever and respiratory symptoms. So either category A, B, or C. Here, this child is already requiring oxygen, probably grunting, having a little bit of distress. Straight away, this child, we can classify them as category C kind of a patient where we need to admit the patient, give a supportive treatment, oxygen, probably IV fluids, probably this child is sick enough to deserve IV antibiotics. We'll go ahead and start them on IV antibiotics. In the light of our discussion today, we are having, so in this epidemic, we need to go ahead and start this child on empirical antiviral also. And probably in next few hours, we will get the labs. 1 or 2 hours, we'll get the counts, the enzymes, and all these things. But the swab may take 24 hours or so for us to get the swab report back. So for all practical purposes, we are dealing with an acute respiratory infection. Most probably, it could be viral, could be bacterial on day one. The labs are supportive towards a viral infection because total counts there is leukopenia, platelets are trending towards slightly on the lower side, and there is transaminases are little elevated. SGOTPT is slightly elevated. So probably in this monsoon season, we need to think about coexisting dengue also. In this child, if the child is looking sick, probably it will be worthwhile to get a test done for dengue and to rule it out also. And of course, after 24 hours or so, when we get the swab report, that will be kind of confirmatory. In suspicion, we've already started this child on Oseltamivir. Whether to continue or to stop, that discussion we'll have later. So that is dependent on what the nasopharyngeal swab is showing. So for all practical purposes, this is the typical presentation of a flu or a flu-like illnesses that we are getting these days.
Thank you. And then this was another case, again, a 3-year-old child with cough and fever for 5 days, where fever was not coming down. The counts were normal. And then the nasopharyngeal swab showed H3N2. Another child where, the counts were normal, but the CRP was a bit on the higher side. And the aspirate showed H3N2. And so, Dr. Somashekar, what are the factors on which clinical response to oseltamivir depend in a given child?
See, once you are started with the high index of suspicion, clinical score or clinical symptoms matters a lot. See, here the main is that it is not only the upper respiratory symptom or a lower respiratory symptom. Baby will have other feature like excessive tiredness, decreased activity, poor feeding, vomiting and diarrhea. First and foremost, the fever starts coming down and the activity improves. That's very good indicator that it is working. Apart from that, other symptoms started improving, like cough, cold, or the if it is associated, the progression of symptoms starts there. Like you will not end up with the progressive respiratory distress and other thing. First and foremost is clinical parameters like fever, cough, cold, activity improves, appetite improves. After later, like if you are thinking like radiologically, if the patient is admitted, you can expect a radiological outcome or decrease in the whatever the point of whatever the pockets can come down or not progress further. That can be taken. But always when you're checking for the clinical improvement, clinical response, physical response is important.
Sure. And I'm sure that once you start oseltamivir before 48 hours, the response is supposed to be much better. And of course, this is a child who rather deceived us. He came for cold and cough and had high WBC count, high CRP, continued to have high fever, and the aspirate showed adenovirus positive. This is another child, and Dr. Anil, you can just have a look at the clinical presentation that this child was a 5-year-old girl with a high fever for 5 days, cough and cold for 5 days, but the child was sick and had mild wheezing, but there were no crepitations. And just would like to tell our audience whether such children should be managed with antibiotics or whether we should do something else or wait or start antivirals. As to what is your opinion? Yeah.
Yes, sir. I think as pediatricians, antimicrobial stewardship is drilled into our head, and we always try to follow that antimicrobial stewardship at all positions. So here we have a 5-year-old child. Even on day 5, the child is still running a high fever, cold and cough is there, and becoming more sicker. So in this epidemic, this could very well be a viral illness. Even on day 5, it could still be a viral illness because there is lack of localization on the clinical examination. But still, if someone is becoming sicker on day 5, I think they deserve to be started on IV antibiotic also, along with the empirical antiviral agents. And antibiotics need to be started. This is after collecting the appropriate cultures, we need to start them on IV antibiotics. And what comes up later in the nasal swab or what comes up in the labs later on can dictate our therapy later on.
Right, right. So accordingly, this child was put on amoxiclav. The WBC count was 2800, neutrophils 10, lymphocytes 70, and the CRP was 34.7. And this particular child was put on oseltamivir. Of course, the nasopharyngeal swab, which was awaited, it showed rhinovirus positivity. So with this, I would like you to elaborate a bit more about the sensitivity of influenza PCR and treatment decisions.
Yes, sir. This child was rightly started on the co-amoxiclav, probably intravenous co-amoxiclav was started. We see that the CRP is slightly elevated, but the surprise for us was in the nasopharyngeal swab. We were expecting flu-like illness, but here there are different unrelated virus, like a rhinovirus has turned up positive. So in such a situation, our nasopharyngeal swab, which is done nowadays, will contain a multiplex PCR also, along with the influenza. Many a times it will cover for this rhinovirus. It may detect adenovirus. It may detect RSV. It may detect COVID also. So we do it as a multiplex panel. So as a clinician, before ordering the swab, we should have a clinical syndrome in mind as to what is the likely etiology. So without knowing that, we shouldn't be ordering for a test. So here we had influenza-like illness presentation where we expected one of the viruses to come positive. Here the virus which has come positive is the rhinovirus. And rhinovirus, like we know, it causes a localized disease. It usually causes nasopharyngitis or just a nose block. Very rarely it can, very small children, yes, it can go down the lung and cause a lower respiratory tract infection also. Since it's a 5-year-old child, it is kind of not correlating the rhinovirus being positive in the nasopharyngeal swab. In such a situation, we would continue with the IV co-amoxiclav, which has been started. And decision regarding the continuation of the oseltamivir will depend on the local epidemiology, what is going on, what is the pattern of spread which is going on, because the PCRs are quite specific and sensitive in picking up the influenza also. So if you're strongly thinking in terms of influenza also being positive, yes, will be justified to continue the oseltamivir, which we have started for 5 days also in this patient.
Right. Maybe at the same time, you could tell our listeners as to what could be the cause, for the throat swab coming negative for influenza when actually the child has influenza.
Yes, sir. The sensitivity of a well done swab, if we are connecting it from the deep in the nasopharynx or from the our pharynx, the sensitivity is as high as 95%. If it is improperly collected, like very too much anterior from the nose, or if it doesn't contain enough respiratory droplets, the sensitivity drops down to close to 60 to 65%. So even though the WHO tells us that since the sensitivity is high, the swab results come negative, you can go ahead and stop the empirical oseltamivir is what the WHO tells us. But I think as clinicians, our guess is usually influenza-like illness. If we are thinking very much strongly in favor of influenza, and there is no other virus or a bacterial syndrome to explain this illness, I think we'll be justified to continue for 5 days and complete the treatment.
Right. Thank you. Dr. Somashekar, she's a 7-year daughter of a IT sector parent and has high fever for 3 days with throat irritation. And this child has examination after 2 days, and the parents are worried, and the throat is showing mild congestion. The child has been prescribed paracetamol. But in view of the flu and the adenovirus around, the parents do not appear to be very well convinced with plain simple paracetamol being given. And that's why our listeners would like to know whether experts would look at this case in the same way and continue only paracetamol, or whether they would go ahead and do something else in the form of investigations like CBC, CRP, do a throat swab, or start empiric oseltamivir, particularly because the parents are from the IT sector and they are well educated, and that's why probably some of them many times they pressurize us to do something more in view of the exam, and it's a very common scenario. So how would you approach such a situation? Yeah.
First of all, this is 7-year-old, 3 days of fever. That's all. Ask them to plot the temperature. That's very important because maybe the first day it is 101, second day it is 100.5, third day maybe 100. Please show them all these 3 days he has got fever, but it is reducing. One thing. But related to exam, you know what, corporate culture, every month, every week they have a test. So that examination system is there. Please reassure them and just tell them about whatever the indication we are going to start either investigation or the antibiotic or oseltamivir. Just explain the symptom, whatever the red flag signs, other dangerous signs, or when to come on follow up. As you said, a follow up is where we learn and we'll make sure them that they know better, they'll understand. So after 3 days, we'll review once again, take a call, because this baby is not in any emergency. It's a OPD case. Treat as OPD with a symptomatic or a supportive care. Please speak to them, spend some time. That's more than enough.
Thank you. And then, Dr. Anil, this is a 3-year-old boy with cough for a week and high fever for 3 days with crepitations. In view of this picture, the child has been put on coamoxiclav and has been admitted for persistence of fever. He has received IV amoxiclav. The WBC count is 7,750, neutrophils 49. The CRP is 2.8, and throat swab is influenza A positive. That's why oseltamivir has been added. And the question that we have kept pending for some time is whether after addition of oseltamivir, what do we do about this IV augmentin? Whether we discontinue that or continue that. So we would like to have your opinion about such a situation.
Yes, sir. Just as we discussed, many a times we may have to start antibiotic also along with the antiviral. But at the same time, antimicrobial stewardship, we should be very much watchful to de-escalate and stop the unnecessary antibiotic, which might have been started on day 1 or day 2. So here the clinical picture is very clear. The counts are more of a viral kind of a nature. The CRP is negative, and the swab also has detected influenza A being positive. So within the first 24-48 hours, we also get to know that if the fevers are coming down, child is becoming active and all that. So in such situations where the swab is positive, and there is no other localizing signs, like there is no lobar consolidation, or there is no tonsils which are getting follicles and all these things. So I think we are justified in stopping the antibiotic which was started earlier.
Very good. So basically, this antibiotic stewardship is very important. And if the report, PCR report comes positive, then one should not continue with the antibiotics. Depending on the clinical scenario, one can either stop it, but at least should not escalate these antibiotics. Okay, we have had some cases of complicated influenza, and one of them was a 1-year-old child who came for fever, cold, cough, and status epilepticus, and the nasopharyngeal swab showed H3N2. The counts were normal, and the MRI showed non-specific encephalitis changes. The CSF was normal, and he was diagnosed as a case of influenza encephalitis. So, Dr. Anil, being an intensivist, I would like you to elaborate a bit more about the neurological complications of influenza.
Yes, sir. After the respiratory tract, it's the CNS which takes a hit in influenza viruses. So we have seen that increased admissions mainly for the febrile seizures we are getting because of the such high abrupt onset of fever. We are getting increased admissions for febrile seizures and atypical seizures. Many of them are having repeated seizures one after the other. And we have seen that few of the children are becoming little delirious, especially little older children at the height of fever are become delirious, or they're getting admitted with febrile delirium. And also febrile encephalopathy. They are not regaining consciousness between the episodes of seizure. They're becoming comatose. So when we had worked up one of the children who presented like this, so the CSF was bang normal. There was no cellular response. But the imaging had shown us bilateral thalami getting involved, just like our JE kind of a picture where bilateral thalamus was lighting up. In fact, we could see few areas of necrosis also appearing inside the thalamus, the condition what we call it as ANEC, or acute necrotizing encephalitis kind of a syndrome. This is more like an immune mediated phenomenon because we have a febrile respiratory illness, the body reacts, and because of the cytokines which are released, the CNS takes a hit. So the CNS is getting involved without a direct invasion of these viruses. So of course, when we do an LP, we won't be able to demonstrate the cellular response or the virus in the CSF. And very rarely, especially in the influenza B kind of a scenario, we are getting lots of children who are coming with progressive weakness or severe pain in the legs. They're unable to walk, or their gait is becoming waddling and all this. So when they're carefully examined, we get to differentiate myopathy from neuropathy. Sometimes a nerve conduction study may be useful in differentiating between the two. And others, like aseptic meningitis kind of a picture is also seen where they're having little bit of neck stiffness can be there, which will resolve within a day or two. If they're active, playful, they don't have any focal signs, we may not do an LP in such situations. It will resolve usually in the next couple of days. And very rarely, yes, we have seen renal complications and hepatic complications. Not so much so, but these are the textbook descriptions of the progressive and multi-organ involvement of the influenza viruses.
So that's a very good piece of information. And many of us have seen simple febrile convulsions, most commonly coming with influenza in this season. And of course, we have also seen the co-infections of influenza with RSV, and they merit their own management. So there have been plenty of cases this season which came with influenza and RSV. We have already
As such, there
discussed
was
the
a mention
respiratory
about
complications.
contraindication. As such,
Yeah,
I
yeah.
don't think there is any contraindication, right? Anil, there is no contraindication for
For
oseltamivir.
Oseltamivir, sir.
There was
Yeah,
Sarvas mentioned there.
there is no contraindications for Oseltamivir at all, sir, because it's a very safe drug, well-tolerated drug.
Yes.
Usually, unless there is specific hypersensitivity which is documented, it can be
Which
used.
is right.
Sure. Yeah. So we have discussed some of these complications related to the respiratory system, and also there have been, complications like toxic shock syndrome and cardiac complications like myocarditis. We have already discussed a bit of, myositis, which is more common with influenza B in boys, particularly where there is bilateral gastrocnemius and soleus involvement. And these children, they come with severe bilateral calf muscle pain and inability to walk. We also discussed about the hepatic involvement in the form of Reye syndrome. when children with influenza B are exposed to salicylates. So finally, we'll have some quick questions, and some of us already we have discussed. So the ones which we have not yet touched upon, like for example, Dr. Somashekar, an elder sibling of an 8-month-old child is admitted with influenza A, and the 8-month-old child now develops fever. So what do we do? Whether we should start oseltamivir for the 8-month-old child?
As we said empirically, if the child is less than 2 years, ideally we should start. This is because it's 8 months old. Please start. Maybe they are twins. Better to start.
Okay, very good. Dr. Anil, if the child is not accepting the medicines, is there any alternative?
No, sir. Currently, the IV alternatives are not available in our country. Oseltamivir is the only drug. So we can utilize the other methods, like probably giving it in small aliquots in dropper, or divide it into much smaller aliquots and giving the child, or giving it in a different base can be done. But there is no alternative right now.
Okay. And
Yes.
Dr. Somashekar, shall we give chemoprophylaxis to all the household contacts?
Yes. If you got high index association, it is swab test has come positive. Better to give chemotherapy, especially the extreme ages, or they got immunocompromised or comorbid condition. Please give them.
Okay, so those categories which we discussed under category 2, the
Yeah,
high risk
category B and
contacts,
category
they
C.
are the ones, yeah, because
Yeah.
I'm sure there is always someone in the family who has diabetes or steroids. And as we said earlier, illness, which spreads from children to others. So others, particularly, they are not immunized, because not many are very particular in taking that flu shot every year. So it is prudent to protect them with chemoprophylaxis given for 10 days. Dr. Anil, what about para-influenza viruses? Does oseltamivir work on para-influenza viruses?
No, sir. Oseltamivir has no action on para-influenza viruses and should not be used when it comes positive. Para-influenza viruses we get in a clinical scenario of acute croup in smaller children who are getting admitted with croup syndrome. Usually we see para-influenza coming back as positive.
Right.
Yes.
Very good. So we have discussed, almost all the important points related to influenza and oseltamivir, and we have learned that this virus is a fast and a furious virus with abrupt onset, high transmissibility, rapid progression, complications like ARDS, which may develop very fast. And that's why we also have to be very fast in starting antivirals like oseltamivir. And I'm glad that our influencers of influenza have narrated as to how to control this naughty, drifty, and shifty virus. Okay. So I must say this has been FLU. It's a fantastic learning update from both of them. Of course, in addition, we must remember to prevent the transmission of the virus by the sanitization, mask, and social distancing, cough etiquettes, where particularly, we advise people to cough in the elbow and not in the hands as far as possible to avoid transmission, and use certain precautionary measures related to the hand, like frequent washing at the hands, avoiding a handshake, avoiding hand touching, using a handkerchief, and keeping others at a hand's distance. And this is true for almost all those respiratory viruses like RSV also. And it is very important that the medical fraternity and the paramedical staff all take this care, because we are the ones who are exposed to children day in and day out. Children, cough directly on our faces, and we are the ones who are maximally exposed. So in addition to these measures, one should also remember to have flu vaccine annual shot. And I always say, along with happy birthday to you, immediately the next sentence which should come is happy birthday to flu. And all of us must take this vaccine every year, and birthday is the best day when we can remember to take this particular shot. So with that, we are coming to the end of this particular discussion. And as I already said, saying namaste is the best way to either greet or say goodbye to other person, so that it will also convey our sentiments and also prevent transmission of these respiratory viruses. So with that, I thank Dr. Anil and Dr. Somashekar
Thank
for
you, sir.
giving fantastic answers, and
Thank you.
also Hetero Pharma for allowing us to discuss these issues with our listeners. Thank you very much.
Thank you,
Sir,
sir.
well moderated, sir. Pramod sir,
Thank you, sir. As usual, like
Yeah, very
Thank you, sir.
lively. Yes, nice inputs. And
Thank you.
sir, thank you. Thanks, Dr. Zog. Thanks, Dr. Somshekar. Thanks, Dr. Anil. I take this opportunity to wish all of you happy Diwali.
Happy
Happy
Deepavali.
Deepavali.
Yeah, it's coming.
Thank you,
Yeah.
sir.
Happy Deepavali.
Thanks, Sanjana. Happy Diwali, Samruddhi. Thank you so much. And thanks all the field staff for FEDRO for this support. Thank you. We can log off and
Thank
wish you a very good afternoon.
Thank you,
Thank
sir. Thank you
Bye.
so
Thank
much.
you.
Bye.
Bye, sir.
Namaste.
Good day.
Namaste.
Yeah.
Namaste.